Hello and welcome. Our work today is in the spirit of moving forward toward reconciliation and anti-racism through culturally safe care. We'll begin with a land acknowledgement. To recognize the land is an expression of gratitude and appreciation to those whose territories we reside on. Land acknowledgements are not solely about the past. Canada's treaties and ongoing relationships with Indigenous peoples is a current and ongoing process. As we gather today in this virtual space, we acknowledge and pay respect to the many First Nations, Inuit, and Métis people and the traditional territories on which we live, work, and play. I would like to acknowledge that I'm speaking with you from the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. This meeting place is home to many Indigenous people from across Turtle Island, and I'm grateful to have the opportunity to be here with you today. My name is Dr. Jennifer Bryan. I practice emergency medicine at the University Health Network in Toronto. I'm an assistant professor, I'm an associate professor in the Division of Emergency Medicine at U of T, as well as assistant director of the Clinical Epidemiology Program of U of T's Royal College Emergency Medicine Residency Training Program. I am the founding chair of the UHN ED Sickle Cell Working Group and the founding chair of the CAPE Anti-Racism and Anti-Colonialism Committee. It's my pleasure to moderate this webinar this afternoon. Our webinar topic was independently conceived by the Scientific Planning Committee, Drs. Eddie Lang, Stacy Kitts, Kirat Grewal, and Peter Heraklius, none of whom had any conflicts of interest to declare. My disclosures are as follows. These are the disclosures for our speakers today as well. This presentation was made possible by an education grant for Novo Nordisk, whom I would like to thank for their generosity. All efforts were made to mitigate any potential biases. Our speakers this afternoon are Dr. Dominick Shelton and Dr. Ziad Solh. Dr. Dominick Shelton is an emergency physician at Sunnybrook Health Sciences Centre in Toronto, as well as the medical director of quality and safety in the ED. He's an associate professor in the Department of Family and Community Medicine at U of T. He was on the expert panel that developed the Ontario Ministry of Health's Clinical Handbook for Sickle Cell Disease Vaso-Occlusive Crisis. Dr. Shelton co-founded Camp Jamoke, a camp for children with sickle cell, and was the camp's former medical director. Dr. Ziad Solh is a hematologist and transfusion medicine specialist at London Health Sciences Centre and an associate professor at Western University. He currently directs the Adult Hemoglobinopathy Program at London Health Sciences Centre, where he sees patients with sickle cell disease and thalassemia. And he is the head of the Transfusion Medicine Division in the laboratory. We're looking forward to an interactive session with you today and encourage you to use the chat feature to submit your questions. We'll try to address as many as we can during the Q&A after each section. We'll also be doing some audience polling throughout using Mentimeter. And you can access that on menti.com as shown, or using the QR code on your screen. We'll also put a link in the chat. You'll be prompted to enter the code on the screen and then answer each question as they come up. Please be sure to click submit so your votes are counted. September is Sickle Cell Awareness Month. People living with sickle cell disease rely on emergency departments for care when experiencing acute complications of this lifelong disease. It's essential that we know how to provide high-quality care. Recent updates to Ontario's quality standards for sickle cell disease provide us with new guidance to be able to recognize and optimize outcomes for these patients. Our learning objectives for today are displayed here, and I'll give you a moment to review. And now I'll hand things over to Dr. Solh to provide a brief overview of sickle cell disease. Dr. Solh.
Thank you so much, Dr. Bryan, for the introduction. And it gives me great pleasure, and it's an honor to be here with everybody to speak about a disease that's very near and dear to my heart, which is sickle cell disease. I'll be speaking first, and then Dr. Shelton will start a case afterwards. So just an introduction for those of us who haven't seen the pathophysiology in sickle cell disease in several years since medical school. But you may recall that sickle cell disease is a monogenic condition where a single mutation leads to quite a devastating condition. So changes in the DNA on the right side is sickle cell disease, and on the left side is the unaffected individual. Changes in the DNA lead to a change in hemoglobin, which is a change from hemoglobin A for adult to hemoglobin S for sickle cell. And this then translates into what we see under the microscope, the shape of a sickle or a crescent moon almost, that leads to several changes, microvascular changes that we will discuss, and all of the complications that can present to your emergency department. Next slide. So this is what we're talking about. So the red cell changes from a nice biconcave, squishy, donut-shaped red cell into a more rigid, sickle-shaped red cell that is not appropriate for laminar blood flow, and it leads to vasoocclusion. This is vasoocclusion of red cells, so it's not a blood clot. Blood clots are platelets. So you can imagine an organ that's waiting for oxygen on the other side of this microvascular environment will be starved for oxygen and become ischemic. So whether it's bone leading to bone pain or the brain leading to stroke, this vasoocclusive crisis, as we call it, leads to several multi-organ complications. Next slide, which leads to tissue hypoxia, as I mentioned. So some of the acute complications you may see in the emergency department are stroke, as well as meningitis due to the asplenic nature of patients with sickle cell disease, bone marrow infarction, which is quite painful, osteomyelitis, and then acute chest syndrome, splenic sequestration, and priapism. The list does go on. Chronic ones that we deal with more in the clinic, and preventative care addresses them. We spend a lot of time addressing them in clinic, are hemolysis and hyperbilirubinemia, skin ulcers, and delays in endocrine function, as well as pulmonary hypertension. So multi-system disease affecting both pediatric and adult patients, as well as the geriatric patients. Next slide, please. I did want to mention that there's a misconception that sickle cell trait is very similar to sickle cell disease, and it is not. However, sickle cell trait can be co-inherited with other mutations like the hemoglobin C or beta thalassemia to lead to quite severe sickle cell disease. So if you see a patient who has an unusual, genetic, mention of something in the chart, know that it could very well be sickle cell disease. And if you have questions about whether this is just a trait, a carrier state, then please call a hematologist. If you click one more time, you'll see that this is a spectrum in the table. Severe sickle cell disease can have several genotypes that lead to different phenotypes. So it could be SS, the most common, or S beta 0, S beta plus, the list goes on. More moderate sickle cell disease conditions would be hemoglobin SC or hemoglobin S beta plus. The list goes on to more mild hemoglobin genotypes and phenotypes. However, some SC patients, for example, that are listed here in the moderate section can be even sicker than some of the SS patients based on the environment the patient lives in or other genetic mutations that can improve or worsen the phenotype. Next slide. I will hand it over now to Dr. Shelton. Thank you.
All right, thank you for that. So we'll jump right into the first case, and that is a 24-year-old male with sickle cell disease who presents to the emergency department complaining of pain in his limbs and back. So the story is that he's had a 3-day history of severe pain in his bilateral legs, arms, and lower back. And he states that it feels like his previous sickle cell pain. So this is an important historical question to ask any patient with sickle cell disease that presents with pain. And really what you're doing here is you're establishing your differential diagnosis and whether or not you can start to focus your differential early on. And he also states that there's been no improvement with analgesia. Another important question, because the answer to this is going to determine how you treat the patient in the emergency department in terms of the analgesia that you provide. And you want specific details. And in this case, the patient does say that he's been taking morphine 5 milligram tablets, 4 doses over about the last 24 hours. Next. And the physical exam is essentially normal in this patient, including vital signs. Next. So what is your likely diagnosis for this patient? And in any sickle cell patient that presents with pain, there are 3 things to always consider in making the diagnosis. And that is their presentation of pain typical for their usual painful crises? Number 2, is there any complication of sickle cell disease that you are considering in this patient that also has pain? And so examples would be whether it be osteomyelitis, septic arthritis, acute chest syndrome, and thirdly, whether this is could this possibly be something totally unrelated to sickle cell disease that can happen in the general population. Next. So in this patient, all things are pointing towards vaso-occlusive crises. It is the most common reason why patients with sickle cell present to the emergency department. And as Dr. Solh explained, the pathophysiology of this condition. You should be aware that the vast majority of vaso-occlusive crises is managed at home by the patient. So when they present to the emergency department with a painful crisis, it's a reflection of the severity of the pain. Common sites include the lower back, limbs, ribs, and triggers can include infection, dehydration, extreme temperatures, but sometimes there is no identifiable trigger. Next. So a polling question for you. Which of the following analgesia orders would you initially write for this patient? And the options are morphine 5 milligrams IV, Q 30 minutes PRN, morphine 10 milligrams IV, Q 30 minutes PRN, ketorolac 15 milligrams IV, hydromorphone 1 milligram IV, or hydromorph 2 milligrams IV, or hydromorph 2 milligrams orally. So I'll give you a few seconds to answer this question. And I should state that there is no one correct answer, but there are better answers. Okay, so I'll give a few more seconds here, maybe 5 more seconds to reply. Okay, so we're seeing a distribution here of answers, and that's really what I expected in terms of seeing the varied response. And like I said, there's no one correct answer. But let me explain why B and D, so morphine 10 milligrams and hydromorph 1 milligram are the, hydromorph 2 milligrams IV are the better answers. So if we can go back, I still want to explain this. So essentially, if a patient is taking oral opioids at home and is not able to cope with their pain, leading to a visit to the emergency department, it's a reflection of how severe the pain is, I mentioned, and the fact that they're going to need stronger opioids and usually in the parenteral form. And so therefore, morphine 10 milligrams and hydromorph 2 milligrams IV would be more appropriate for managing this patient. Ketorolac is an option, but again, if a patient's been taking oral opioids at home, NSAIDs alone are unlikely to control the pain. However, NSAIDs are certainly appropriate to use as a part of the multimodal analgesia to give it in addition to opioids. Next slide. So there are some emergency departments that have sickle cell disease order sets in order to standardize the care that is provided to these patients. And within the order sets are orders specifically for opioids. And here's an example of the sickle cell order set that's used at University Health Network in Toronto. And the order set is divided into, for the analgesia, is divided into two. So for opioid naive and opioid tolerant patients. And it's then further subdivided into initial pain control and then ongoing pain control. So here we see the order set for opioid naive. The initial pain control would be morphine 5 milligrams IV or sub-Q, Q30 minutes PRN until the pain is controlled, or the corresponding hydromorph 1 milligram IV or sub-Q, or morphine 10 orally or hydromorph 2 milligrams orally. And then the same doses for ongoing pain control, but just the dosing interval is spaced apart. Next slide. And for the opioid tolerant patient, it's higher doses. So the morphine 10 milligrams IV or sub-Q, and hydromorph 2 milligrams IV or sub-Q, or hydromorph 4 milligrams orally. So one point just to mention here is that some people may say giving opioids Q30 minutes is too long and that it should be given more frequently. And that would be appropriate. And the literature actually does support shorter dosing intervals, as short as Q5 minutes. But if one is going to utilize that approach, then it would be a lower dosing opioid dose. So like morphine 5 milligrams and hydromorph 1 milligram dosing. And the patient would need certainly close monitoring, and there would be increase in nursing utilization for such an approach. Next slide. So several organizations, frankly, internationally, have established quality standards for the management of patients with sickle cell disease. And one thing that's consistent amongst these quality standards from the different organizations is the timeliness of administration of opioids of analgesia to patients presenting with painful crises. And so here's an example of the Ontario Health quality standard, which states that pain management should be started within 30 minutes of triage or 60 minutes of emerge presentation. Now, I know many of you are probably going, wishful thinking in light of the many competing priorities that we face in the emergency department, particularly at triage. But I do feel that this is a goal that we should all strive towards. And the reason why is that this is a chronic illness that has recurrent painful, severe painful episodes leading to emerge visits sometimes. And it really is the humane thing to be treating these patients in a timely manner with analgesia and not to leave them languishing for hours waiting for analgesia. Right. So next slide. So we focused on timeliness of opioid analgesia, but other things to consider in the management would be oxygen and IV hydration. Now, for those of you who have been practicing long enough, you may remember that years ago, we used to routinely give supplemental oxygen and IV fluid boluses to patients presenting with painful crises. However, evidence has showed that there is some potential harm from doing that. So it is now limited to really patients who are hypoxic or patients who are hypovolemic that require oxygen and IV fluid bolus. Although maintenance fluid is still recommended, at least in if you are going to give maintenance fluids, it would be a hypotonic fluid. A warm blanket goes a long way to provide comfort for these patients who are having severe pain, to help them in coping with the pain that they are managing. Next slide. So as with all patients that we see in the emergency department, we're tasked with disposition. And some things to consider in sickle cell patient with vaso-occlusive crisis, whether to manage them as an in or outpatient, are the following. So are there any concerns about potential complications of sickle cell disease in this patient? What's the degree of pain control that you've been able to establish on the patient in the emerge with the analgesia provided? And the patient's previous experience. They know their disease. They know, based on previous experience, often what is required. So I think it would be very appropriate to ask the question to the patient, based on your previous experience when you're at this point in your illness of a painful crisis, what usually happens? Do you feel that you're able to go home and manage with pain medication orally, or do you usually get admitted to hospital? And then whether there's appropriate timely follow-up with either their primary care physician or a hematologist. Next slide. And a few misconceptions to address around patients with sickle cell. So first of all, you do not need to wait for any lab results before providing analgesia to these patients. Vaso-occlusive crisis is a clinical diagnosis, and there is no lab result that is going to make that decision for you as to whether you should provide pain relief or not. Discordance of pain and physical state. From early on, from a young age, people with sickle cell are taught how to cope with their pain. And there are pharmacologic and non-pharmacologic ways in which they manage their pain. And from the non-pharmacologic standpoint, they're taught modalities of distraction. And so that can manifest itself in the emergency department as a patient using technology on their computer, on their phone, speaking on the phone, texting. And that can be misinterpreted by a healthcare provider as being, well, they're probably not in that much pain if they can do X, Y, and Z. And a healthcare provider may even go as far as stating or thinking, at least, that they may be drug seeking. So, the reality is that we're in an era of an opioid crisis, and we're dealing with a disease that causes severe pain that requires opioids and sometimes high doses of opioids. And so there is this stigma that is applied to some patients with sickle cell. Important to realize that patients with sickle cell disease are not driving the opioid crisis. Evidence shows that less than 5% of patients with sickle cell use opioids for reasons other than actual pain control. And then there's racial bias. This is an illness that predominantly affects Blacks. And, racial discrimination is a reality. And unfortunately, healthcare is no exception to that in terms of systemic racial discrimination. And so you can imagine how someone with sickle cell, if you layer on the fact that they may present to the emerge, and if they wait a long time for analgesia and they're in severe pain, and then there's a perception or it's actually, there's this impression that they are drug seeking, and then the racial bias towards them, all those things layered, you can understand why many patients with sickle cell have had negative experiences in the emergency department. So just keep that in mind with your interactions with patients with sickle cell. Next. Next slide. So just to bring the patient's voice to this presentation, a quote from a patient with sickle cell: "There is a visual disconnect. You are not bleeding or broken. ED is for emergencies. It is an emergency. That is why I'm here. Yes, I look this way, but you cannot see my pain." Next. And next. All right. And so at this time, I will turn it over to Dr. Bryan to moderate any Q&A.
Thank you so much, Dr. Shelton. And a reminder to everyone that we're keeping an eye out for any questions that you have in the live stream chat. So go ahead and throw them in there. We'll be having Q&As intermittently throughout the session. Dr. Shelton, a number of really important points that you touched on. I wonder, one of the myths that you mentioned was that you can't tell by someone's lab work or their vital signs if they're having a vaso-occlusive episode. So can you speak to how do you know that someone's having a vaso-occlusive episode in sickle cell?
I think you basically need to listen to the patient, right? If they have the illness of sickle cell disease and they are presenting and they are giving you the symptom, the subjective symptom of pain, I think this is where we need to have trust in the patient that they are experiencing pain, because we know it's a disease that causes severe debilitating pain. And I think to question them otherwise, I think is to do not do justice for the patient. So and like I said, it is a clinical diagnosis. There is nothing that is going to sort of give you objectively the answer. So we have to rely on subjective, and that is the patient's history.
Thank you so much. And then we have a question in the chat, two questions actually. So one is, you mentioned overhydration as a problem. Can you elaborate on that a little?
Yes, and you know what? I think I'm actually going to defer most of my response to this to Dr. Solh, because he is actually going to be touching on it during one of his cases. But basically, to say that there is evidence to show harm, and one is their hypochloremic metabolic acidosis that the overhydration can cause. It's also being linked to atelectasis, and atelectasis can predispose to acute chest syndrome. So those are some of the ways in which overhydration can cause harm, but he'll get into the specifics in terms of the actual pathophysiology as to why overhydration can cause harm.
Excellent. Yes, lots still to come in this session. Another question in the chat is about whether there's any role for D-dimers in patients with sickle cell.
It's a good question. And obviously utilizing D-dimers, because in our differential, if they were presenting with some form of chest pain, that you'd be considering pulmonary embolism in the differential. I would say that, I mean, when you think about it, there are other reasons as to why this patient may have an elevated D-dimer. So it really comes down to, is there evidence to show its validity in this patient population? That I don't know for sure. And again, this is one that, let's see, Dr. Solh can touch on later on. But I just think that, the reality is that many patients where you're considering pulmonary embolism because they're presenting with pleuritic, like a sickle cell patient, they're presenting with pleuritic chest pain, they're short of breath, they're hypoxic, that often the leading diagnosis is going to be more likely acute chest syndrome. And then if they're not responding appropriately to the management, then this is where pulmonary embolism will enter into your differential. you know, as opposed to ruling it out from the get-go. So again, we'll touch more on that later.
Excellent. Thank you so much. We do have some other questions in the chat. I'm going to save them for a little later on because we are going to hand things over to Dr. Solh for our next case. Dr. Solh.
Yeah, thank you. That was a great discussion. Yeah, next slide. Great. So my case will be a little bit of a different presentation, very common as well. And I will touch on some of the questions that came up. So this is a case of a 27-year-old male with hemoglobin SS, sickle cell disease. His chief complaint was shortness of breath. And he says that he's actually had chest pain for about 2 days now. 4 days ago, he had a cholecystectomy, which is very common in sickle cell disease. Almost all of our patients get a cholecystectomy because of hemolysis leading to gallstones. He's very stable in front of you, but he is saying he has shortness of breath and chest pain for 2 days post-operatively. So now you examine him and you find that his fever, his temperature is high. He has a fever. His vitals are in front of you. He has a bit of tachypnea, and questionable whether we call that hypoxemia or not, but not 99% at room air, which is a very realistic case. Next slide. So I'd like to get a sense from everyone, given just your raw knowledge of sickle cell disease and medicine in general, what would a case like this of shortness of breath and chest pain post-op lead you to think about? On the differential is acute coronary syndrome, and I want your top answer, your most likely thing that you're going to be most worried about. Acute coronary syndrome, like a heart attack, acute chest syndrome, pulmonary embolus, pulmonary hypertension, or a bone, rib, vaso-occlusive pain crisis, or a pneumonia. And again, there's not one correct answer. We just want to get a sense. I'm told there are 39 people, so I'm waiting for 39 responses. Okay. We've got 4 responses so far, 5, 6. Come on, you can do it. 7. You might get this case tomorrow morning. So all of our operating rooms are now open to elective surgery after COVID. So we're getting all of our patients, all their cholecystectomies that they've been waiting for. Now winter is coming. So with cold weather comes pain crisis and vaso-occlusive crisis and everything like that because of vasoconstriction and vaso-occlusion. I'll wait for a few more seconds. Okay, that's great. I'll wait for 10 more seconds. 10. Okay, so that's great. So a lot of you said acute chest syndrome, and a couple said pulmonary embolus, and those are reasonable responses. Pain crisis is also a reasonable response. And pneumonia, I'll tell you in the next slides, it's indistinguishable from acute chest syndrome on chest X-ray. So it's a reasonable response, different pathophysiology, and acute chest syndrome. We do get our patients investigated for that, and I'll tell you why it's unlikely in our patients. So next slide. So we will talk a little bit more about that, but what are your most important investigations? Would you do a CBC with troponins and LD? And I think I just biased you there. Would you do a CBC with a reticulocyte count, get a chest X-ray, and do the coags with a leg Doppler? Or is it a CBC, retic chest X-ray, blood cultures, echo CTPA, or bone scan to rule out osteomyelitis? Okay, I'm told only 12 folks have logged into the Mentimeter website. So I won't expect over 40 responses. I'll expect at least 12, I hope. And I'll encourage the rest of the attendees to go on the Mentimeter website. Do folks need the barcode, or do they have access to it if they join late? Perfect. So we have 10 responses. I'll wait 10 more seconds. Perfect. So that's excellent. So in terms of what actually happens in our emergency rooms, a lot of the times, it's, what you have in front of you. We see a lot of variability in practice. We would rarely recommend troponins in our patients, especially given the young age. But I understand in emerge chest pain, angina is a very common presentation. However, in sickle cell disease, we would recommend option C in the red bar over there, where the fever should make us worry about sepsis in an asplenic patient, and a chest X-ray is needed for investigation of a consolidation, which I'll talk to you about why that's a definition in chest syndrome, and a CBC is necessary since it's a hemolytic condition. But fair responses. I understand there's a divide usually. So next slide. So the results of the investigation from your tests are that the patient's hemoglobin appears to be lower than their baseline. Usually it's 80 grams per liter, and now it's 65. Then you do a chest X-ray, and you find that there's a right consolidation, a new consolidation, and think about that in your differential. Think back at the differential that we had discussed. So next slide. So this is a presentation, a classic presentation of acute chest syndrome, very high risk of getting it post-operatively. There are studies showing that 40% of patients with sickle cell disease who go to surgery without any perioperative care specific for sickle cell disease end up with a chest syndrome, 40%. And if you do some interventions that we can discuss, that only is reduced to 15%. So very high risk of post-operative complications. This is why they actually stay in the hospital for a little bit longer. An acute chest syndrome, which is different from acute coronary syndrome, and we add an H for that reason, is defined by the following. So it has to be a new infiltrate on chest X-ray or CT scan or whatever you have in a patient with something that predisposes them to a chest syndrome like sickle cell disease. And it's associated with any of the following. So pretty big, a wide cast net, either fever, cough, sputum production, tachypnea, dyspnea, new onset hypoxia, anything that sounds remotely like a chest symptom. And then this may actually progress quite rapidly to respiratory failure, and it can be complicated by some neurologic events even. What is done in the emergency room in the first 24 hours can actually predict whether they end up getting sicker when admitted, or whether their admission is resolved more quickly. So I think it's necessary for us to talk about the next steps. Next slide. So this is what, let's pretend that, it is a chest syndrome. You're no longer worried about PE and other things. What would your management for an acute chest syndrome be? Now that I told you it's defined as a new chest infiltrate, and choose all that apply. I hope the program gives you the option. Antibiotics, incentive spirometry, IV saline, 1.5 times maintenance, hypotonic fluids, or 1.5 times maintenance, isotonic fluids. And so it's and for all of these. You can do all of them or do some of them. And I think my time is almost up. I just want to make sure Dr. Shelton has time for his case. So you guys chose all the right things. We would not recommend bolus, and I'll talk about why, and we would not recommend isotonic fluids. We would recommend hypotonic fluids, 1.5 times maintenance, giving incentive spirometry, oxygenating, and giving antibiotics because we treat it like a pneumonia. Great. I see we have 30 people now using the program. So chest syndrome is classically where it is actually induced. It can be induced by iatrogenic things. So fluids and transfusion actually stimulate a chest syndrome. So we do have to be cognizant in eMERGE and even on the inpatient floor that fluids and overhydration can induce chest syndrome. So we do not fluid overload. We really try to target euvolemia. Of course, if you have a very dehydrated patient, mucous membranes are dry, you should probably bolus for other reasons. But for the treatment of a chest syndrome or even pain crisis, do not bolus. Do not bolus, and either give 1.5 times maintenance or 1-time maintenance if you're very happy with how they're doing from a fluid standpoint. And we do have, most of our patients do get boluses still, so there's a lot of knowledge translation we're working on with our emergency physicians and even nursing. Next slide. The evidence suggests that hypotonic fluids decrease cell membrane stiffness, and we know in sickle cell disease, the red cells are quite stiff and rigid, so the new ones that are being made are going to be predisposed to sickling when they come out of the bone marrow. So a hypotonic environment will help them not sickle. Isotonic fluids do cause an increase in red cell stiffness. They slow the transit time, so the flow of blood, and they increase the propensity for occlusions, aggressive hydration, to hypervolemic states can be harmful, and we have seen patients, like I said, go into pulmonary hypertension and get chest crisis. Transfusion is also a fluid, and I will discuss that in case number 4. It's also quite harmful in sickle cell disease, except in specific scenarios. Any questions?
Thank you so much, Dr. Solh. I think that helped to answer the overhydration question that came up earlier. I realize that we are a little bit short on time, but I wonder if you could speak to, we have a question again about D-dimers in the chat, about the usefulness. Mm-hmm.
Not useful. That's the short answer. And there have been studies looking at the D-dimers' ability to predict thrombosis, and they're always high, even at baseline in sickle cell disease. So no need to use it. I would also comment that a pain crisis does not need an X-ray of the bone to see what's happening, because the changes, the infarction won't show up for another 6 weeks. And you don't need a rheumatological investigation, which we've seen several times with bone pain and sickle cell disease.
That's very helpful in the emergency department. Thank you so much. I'm going to turn things back over to Dr. Shelton.
Okay, so it's a quick case here. Case 3 is that of a 38-year-old female with sickle cell disease who presents with fever. So she's had a 1-day history of fever with no other complaints, so no symptoms to suggest a focus of infection. And on physical exam, febrile, tachycardic, tachypnea, looks well, and the rest of the physical exam is normal. Next slide. And her routine investigations in the emergency department are normal. So routine blood work, retic count, urinalysis, chest x-ray, all normal, and blood cultures were drawn. Next slide. So management question for you. So how would you manage this patient? Would you diagnose a patient with viral illness, discharge them home with symptomatic treatment? Would you give a dose of ceftriaxone and discharge a patient home with close follow-up? Would you give a dose of ceftriaxone and discharge a patient home with oral antibiotics and close follow-up? Or would you give a dose of ceftriaxone and consult internal medicine or your other admitting service? All right, so give you a few seconds to answer this. All right, so 5 more seconds. Okay, so let me speak to this as the answers may still keep coming in. And so, you know, essentially I'm seeing here giving antibiotics, and that is appropriate. I mean, the underlying issue here is that patients with sickle cell disease are a relatively immunocompromised group, and so as a result are increased risk for serious infection. No, could you actually please go back? I want to still, yeah. And so as a result of that, they do need the empiric antibiotics, and I think the conservative approach of consulting medicine or at admitting service, you will never go wrong with that. And for the most part, that is actually what I'd recommend. Now, there are going to be selective patients where you decide on a case-by-case basis, and sometimes after conversation, discussion with whether it be hematology or a follow-up service, to discharge a patient home on oral antibiotics. But either way, they need that empiric dose of ceftriaxone, and either inpatient admission or home and close follow-up with antibiotics. Next case. And next slide, sorry. And so some points here about fever in sickle cell patients. So as we emphasize here, take these patients very serious. They can get very sick and very sick quickly. And so over time, sickle cell patients become functionally asplenic because of the repeated ischemia and infarction to their spleen. And so their immunocompromised state exists, and mainly towards, or particularly towards, encapsulated organisms like pneumococcus, Neisseria, and H. flu type B. So they should all get a septic workup, or at least a partial septic workup. And it's really the blood cultures that you want to ensure that all these patients get, and empiric treatment with parenteral antibiotic, ceftriaxone, if there's no obvious source. And as mentioned, a low threshold for admission. Next slide. And a couple other points. So it's routine that kids with sickle cell receive penicillin prophylaxis because of their higher risk of infection. And if they develop a febrile illness, that's insufficient treatment for them. Empiric parenteral antibiotics are even recommended in sickle cell patients who, clinically you think they have a very high likelihood of a viral infection because of their higher risk of secondary bacterial infections. And it is recommended, to have antibiotics on board within 60 minutes of triage. All right, and next, turn it over to you.
Thanks, Dr. Shelton. We have a question in the chat about which populations are affected by sickle cell. So we talk about sickle cell a lot with the Black population. Are there other racial groups that are affected by sickle cell disease?
There are. I mean, it's certainly predominantly Blacks and Blacks from the continent of Africa and from the Caribbean, but also Black Americans, Black Canadians, and there are pockets of individuals in other areas, like in Asia, in the Middle East. And there are even times where you will see someone who is white, their race is white, and they do have sickle cell. So I'm sure Dr. Solh can speak to, who is in his clinic, but certainly I think that would be the vast majority would be Black, and then you would have some South Asians, Middle Easterns, and a small number would be white patients. So if someone is I think that the take home line from that question is that if someone says that they have sickle cell and they're not of a Black race, believe them, because they very well could have sickle cell.
Thank you, Dr. Shelton. Now, I'm going to turn things over to Dr. Solh for the last 9 minutes of our session today.
Perfect. Yeah. So case number 4 addresses blood transfusion. So this is a 27-year-old, the same 27-year-old male that had the chest syndrome post-op. He's stable. You've started antibiotics. You had, perhaps you investigated for PE, perhaps you didn't. But either way, they're here and they are wondering for that hemoglobin of 65. What do we do? So next slide. Next slide again. So those are the same vitals. So you recall the hemoglobin was 65 and their baseline was 80. Most hospitals have transfusion thresholds in the emergency department for the general population. And I want to know what you would do for this patient with an acute chest syndrome, knowing what you know. Would you transfuse a unit of red cells because the hemoglobin is under 70? Would you give 2 units because the hemoglobin is under 70? Would you avoid transfusion, or would you transfuse a unit because he has acute chest syndrome? There are no right answers still. There's probably a few that we can rationalize and talk about. Good, so we have 11 responses, so I'll give maybe 5 more seconds. Good. Yeah, so I think the responses we have up here are arguably correct. I would most likely not transfuse this patient, but some will argue that a unit may help, and I'll discuss that decision-making process. For sickle cell disease, the hemoglobin 70 cutoff does not apply. So I know that all patients around the hospital with a hemoglobin of 69 and below will get a unit, no questions asked. But for sickle cell disease, questions will be asked. So I have a system in our hospital here in London where anyone with sickle cell disease needs approval for a transfusion, because guidelines actually say 50 in a well patient is good enough for sickle cell disease. Next slide, I'll talk about why. So transfusion is beneficial in sickle cell disease chest crisis. If that chest crisis is like moderate, severe, you're thinking to intubate, you're really worried about the patient, they're not looking well, and those patients, that's kind of the art of medicine. But for a very mild chest crisis where the patient's relatively well, you can probably get away without transfusion. Now, I think hematologists are split on this a little bit. Some will give right away for a mild crisis, but I have, firsthand seen, a chest crisis progress with just a single unit of red cells. So it is a gray area. And then the role is less well understood in early to mild acute chest syndrome. Like I said, the issue here is that, sickle cell disease, I told you was the red cells are misshapen and, sickled. That will make your blood quite viscous in itself because it's not, there's no laminar flow. It's already a viscous fluid. Now we're adding a transfusion, which effectively raises the hematocrit. And raising the hematocrit is akin to hyperviscosity. So viscosity in sickle cell disease is what results in a stroke, for example, or a chest syndrome. It's really what pushes those sickle cells further into, that position of vasoocclusion and causes ischemia of the lungs. That's what a chest syndrome is. It's ischemia of a piece of lung, very painful. And not easily removed or treated with either IV fluid boluses or transfusion. It's really, you gotta wait, you gotta give it time, you gotta give some anti-inflammatories and spirometry, and things will take a bit of time to readjust. The hemoglobin is never really to exceed 90 if you really need to transfuse. Keep in mind, dehydration can result in a nice looking hemoglobin. So we shouldn't completely trust it without a fluid assessment. But yeah, blood is viscous, blood can be harmful. Next slide. So the indications for red cell transfusion really should just be a low hemoglobin from an aplastic crisis where the red cells are not being made anymore due to a virus, splenic sequestration, hepatic sequestration, really progressive chest syndrome, progressive cholestasis, and acute stroke. Next slide. I just want to quickly mention, I won't go through these, but these are the Apheresis Society indications for an exchange transfusion. So this is where you're not just using a single unit to add hemoglobin, you're actually exchanging those sickling red cells with a normal adult hemoglobin from a blood donor. And so stroke, pregnancy, vaso-occlusive pain crisis that's recurrent, so every month they get one, or perioperative is what we would do. Next slide. These are the non-acute indications. More acute things would be stroke, really severe chest syndrome, priapism, even sequestration. Next slide. So these would be with a consult to hematology, obviously. The complications from transfusion and sickle cell disease are the hyperviscosity I mentioned to you, but also something we don't think about as often is hemolytic reactions. Sickle cell patients, we just talked about, they can come from Africa, India, the Middle East. We have a whole bunch of patients from Syria who had to come with the last Syrian crisis. We have patients from Jamaica, so not Africa, but of African descent. And so their red cells are completely different from the majority Caucasian blood donors in Canada, right? So our antigens around our red cells are very different based on our ethnicity. So what's happening is if we overtransfuse patients who are Black with sickle cell disease with Caucasian blood, they are actually at risk of developing these terrible antibodies. This is a real case that developed an anti-C, anti-E, anti-Duffy, anti-KID, and they are hemolyzing often. We can't find blood for them anymore. So that's another thing we don't often think about with sickle cell disease, that unless you've told your lab this is sickle cell disease, please match for these things prophylactically, we may be inducing an antibody that will result in a hemolysis. Next slide. And this was a real case where we did induce a hemolysis. Unfortunately, the patient's hemoglobin dropped from a nice 90 to 40, and we could not transfuse anymore. That's a contraindication to transfusion. Next slide. And then her hemoglobin A was all consumed because she hemolyzed it, and the hemoglobin S went back up, and then her LD went up due to hemolysis. Next slide. This is a real phenomenon called hyperhemolysis. Thank you.
Thank you so much, Dr. Solh. We've come to the end of our session today, so I want to thank our presenters for their informative talk. You've provided us all with the pearls and tips for the next time we're caring for someone having complications of sickle cell disease in the emergency department. We'd also like to thank everyone who joined in today, the Scientific Planning Committee for their invaluable input, the CAPE staff team for their work behind the scenes, and our IT support. This session has been accredited by the College of Family Physicians of Canada and the Royal College. Please don't forget to complete your evaluation form and claim your credits. A certificate of attendance will be mailed out by CAPE together with the evaluation link. Finally, CAPE has a very interesting lineup of live and on-demand educational webinars planned over the next few months. So please do keep an eye out for more information, and we hope you join us again soon. Thank you again.